Thanks. Thanks, Mike. Let me turn to discussion first, a counter comment from each of the panelists. Briefly note what's been important to you or things that strike you, and then we'll open it up to comments from and questions from the audience. I do want to say, Mike, just in listening to you, I thought your stories and your presentation here did a beautiful job of untangling a really complex area. In fact, I would venture to say that the laws governing when you can take someone's firearms away and when you have to give them back and who is required to give them up and who is still allowed to own them, those laws are so complicated that most people don't understand them. And it's been a successful ploy in keeping people from understanding them, and that keeps people from participating in this part of the policy debate. But I think you've really helped us understand the complexity of these laws, and that's a necessary first step for us to try and say where and how and when they might be better and might be changed. So thank you very much for that. Let me start with Daniel. Comments or quick questions that you might have for the other panelists. Then we'll go to Michael, then back to you, Mike.
This is more of a comment than a question, but the connection with the focus on China in particular and what I was covering, it just hit me that I probably should have shared with you the fact that within a couple of days or so of the Sandy Hook shootings, there was an incredibly parallel event in China where a seriously disturbed man went into an elementary school with a knife and very seriously injured a number of people, but not a single person died. So just this connection about lethality of means, boy, was that a nice contrast, or not a very nice one, but telling contrast when you see what you can accomplish with an assault weapon as opposed to a knife. I've really learned a lot from Michael's reporting. I'm glad I could be helpful to him too, but he really educated a lot of us in the public about these knotty questions, and I want to note that during 2013, a group formed. We came up with a name for the group, a consortium for risk-based firearm policy that Josh Horowitz, who was here, helped pull together, and pull together academics who study mental health, violence, gun policy, legal experts, and so on, and came up with some evidence-based recommendations on this front. They're not a be-all, end-all to cover every base of the solution, but I think they really advance the thinking about this. So perhaps we can discuss that. But part of it is to address these standards so that they're focused on danger rather than a diagnosis or just that someone has been committed. Someone can be committed, but not at all dangerous. One conclusion that group came to is that, again, focusing on risk, that there are a lot of other ways to identify people at risk that have mental illnesses other than through the mental health disqualifications. And so focusing on indicators of substance abuse, which is really what magnifies the risk for when you have serious mental illness for violence. So people with multiple drunk driving convictions, for example, in some states are barred from purchasing, possessing firearms. That seems like a very prudent thing to address violence as well as suicide. So I just wanted to throw that out, that there are other ways to focus on this. It's focusing on the behavior rather than a diagnosis.
Thanks very much, Daniel. Michael?
Following those events in China, there's actually a sequence of attacks in schools in which some were fatal. The Chinese government response was put police and military people in front of every elementary school around the country. So that's how they responded, and then the fear decreased, and so they removed the police. In the last couple of weeks, the same thing has happened. Physicians and nurses are being attacked by patients who are unhappy with the treatment they're receiving. Sometimes it's people who are getting nose jobs or plastic surgery. They're unhappy. They come back and they stab their doctor. And that's happened a lot over the last 2 months. And 2 days ago, the Chinese Ministry of Health placed police in major hospitals around the country to protect the medical staff from violence by patients, just to give you another take on how the Chinese addresses this kind of issue. Predicting individual behavior, be it suicide or violence, there's been decades and decades of research, and I'm very dubious about its ability to do it. There's, the Preventive Medicine Association about last year ago came on, like, can you predict, is it valuable to have physicians to do screening for suicide? And the answer was no, it doesn't really do much. We can predict people who are members of high-risk groups, but an individual, you have 100 people who are severely depressed. Nobody can predict which one is going to suicide in the next month. Similarly with violence, you can have a group of people who are at high risk for violence. Of that 15 people, no clinician or individual using any instrument, using as much detail as you can, is going to predict who's going to be violent in the next month. The research that I see, I've looked at for decades, just can't do it. And so that gives us the problem when you take individuals, you want to limit their access, but you can't predict the individual. You can just say they're a high-risk group. But that individual, which one is going to do it, either suicide or homicide or threatening, it's almost impossible. And decades of research have not come up with any clear answers to doing that. Now, maybe people believe that this will be found. I remain dubious. I think we have high-risk groups, but predicting individual behavior, even though clinicians in the U.S. are held legally responsible. If your patient suicides, you can often be taken to court because you didn't recognize that this individual is at higher risk than anybody else. But it's not, there's a lot of research showing you can't predict that individual risk at the level it's expected legally.
One of the takeaways I thought we had from our earlier discussion about risk prediction is that we are better at predicting low-risk individuals than high-risk individuals. And it may be that you have to opt in by being a low-risk person to have a right to access to some of these
I
things.
actually think that's simply a statistical factor. If you have a rare event, you're going to be very likely to be able to predict the person doesn't have that event. So your negative predictive value is always very high. If you have an event that only happens to 1% of people, you're automatically going to be 99% correct if say nobody's going to do it. So predicting low violence is very easy in a situation in which violence is uncommon. So the ability to predict nonviolence doesn't really help us very much.
That's something we might come back to at a later point. But let me ask Mike if you had a couple of comments, and we'll open the floor to questions.
No, I mean, I think this thread that we're on about violence risk assessment is a really interesting one, and I mean, so, like, it's just really difficult to. So what are you going to do? Like require? So if somebody brings in a note from their psychiatrist that he's not dangerous, is that going to be enough? Or but unfortunately, most of these psychiatrists are sort of relying upon their sort of gut, analysis. Not doing, most of them aren't trained in this. I read a lot and talked a lot with people about this sort of actuarial method where you're sort of rating people on a scale and looking at all these different markers or whatever, so then where do you draw the line? So Daniel referenced some of these other markers, which is a really interesting sort of thing, like looking at substance abuse and looking at previous history of violence, and those would be sort of some out-of-the-box ways to sort of think about this that haven't really sort of been part of legislative efforts. Most of these laws that have been talked about have, I mean, New York passed this law after Newtown, as a lot of people know, is where you know, if a psychiatrist perceives somebody to be dangerous, then they're required to alert authorities, and which will then, if the county authorities agree, then it ends up that they go revoke their permit. So again, it's relying upon a doctor's you know, assessment. I haven't seen any state sort of consider the kinds of proposals that Daniel's talking about. It's definitely an out-of-the-box way to think about it.
Thanks, Mike. The prediction of risk will be a question for us to come back to, but it's clearly something where we need more information. How much time do we have for questions, Kimberly, and discussion? 20 minutes? 5:30. Okay. Let's take 5 minutes, maybe. Shep, then Eric, and Jim.
Right in front of me.
And let's
I
try, and
promise.
if we have comments, let's try and keep it short so we
I
have
just used up
opportunity.
my 5 minutes promising. But anyway, I wanted to make a comment about the concept of screening. Because in public health terms, it's not the way you think about it. What we discovered in many, many studies is that kids who are early, high aggressive, disruptive, have a higher risk as a group to show outcomes of a whole profile of externalizing. And also there is an association with suicide attempts and suicide ideation. But the idea is not that Charlie is going to be at higher risk. We don't know anything about Charlie. What we know about is this group of first graders has, as a group, a higher risk. And the question is, can you reduce that risk early? And what happens to the rates later? And it turns out at that level of thinking about the population, we're in much better shape. So I'd like to get across and have you guys think about screening for Charlie as opposed to identifying groups at higher risk.
Thanks, Shep. Eric?
Yeah, I'd like to make 2 points. And actually, one picks up on what Michael says. Actually, we didn't disagree that much about whether the suicides in China are associated with psychopathology. Indeed, I think they are not. And what I think it teaches us is a very important lesson. In China, when the most accessible means is a highly lethal method, then people who would attempt in terms of their suicidal behavior may be very similar to people who attempt in terms of their suicidal behavior in the United States and Europe, except in the case of getting, in the US, you might get it out of your medicine cabinet and live to tell about it the next morning, even without going to the hospital. In China, you're dead. And so there is an interaction between behavior and means. So when Tom Insel talks about 90% of suicides, he's talking about a Western bias sample. And people argue that too, by the way, so that's not, set in stone. But on the other hand, what I think it's clear is that it may not be so much different in terms of the suicidal behavior in China. People have distress, disruptions, arguments, fights, and they take what's at hand. It's just that what's at hand is deadly. And so the lesson there is highly lethal, deadly, or otherwise means when you have them readily at hand are going to kill you. That's sort of a duh comment, but it's also one that's very important in the public health sense. The second, of course, comes back to what Mark was talking about at the very beginning, which is how are we going to form the kinds of coalitions that bring together people who, while they're not on the extreme poles of disagreement, understand that there's a Second Amendment, there are people who have rights in the mental health community, and that we have to find a way of creating public health approaches because we cannot identify the individuals. And the law enforcement approach of the old days for violence is old. The law enforcement doesn't do it anymore. They've changed to prevention as well. And so you have something like Lock It Up, which is an effort in King County in Washington where they have had a coalition built between the local public health and injury prevention people and the firearms dealers, where they're in fact giving incentives for buying locks, 15% discount if you buy gun locks. Ways of engaging owners and retail dealers in trying to sell a safety device where a lot of people actually agree that the safety device is important. And it's this kind of coalition building. It doesn't ask the gun shop owners to be gatekeepers or to recognize suicidal people. In fact, it moves away from that direction and says, let's build a community of safety, which was in fact the seatbelt issues, the airbag issues. It costs a little more, but there are ways to do things. So I think that out of this effort, we need to think about those kinds of practical things. But a final comment is, I'm not sure who would ever support research on that. Is that an NIH research portfolio? Is that community-based participatory research? Is that the kind of thing that we could get CDC to support? Don't know, but that's the kind of thing that we have to support in the way of research to see whether we can build those coalitions and actually have a safety impact.
Those are excellent comments, Eric. I think if we can identify the questions, that's the first step, and we'll put them out as an agenda for research. Jim, Mercy.
This sort of picks up on what Shep's point, and that is that we don't need to be able to predict these behaviors in order to take public health actions. And one of the ones that I'm very interested in, particularly connected to suicide, is the study you showed by David Brent on the role of physicians or other healthcare providers in counseling families with patients about getting guns or other lethal means out of the homes of people who are at higher risk. Is that the only data we have on that type of intervention? What do we know about the effectiveness of that approach? I know we know that not many physicians do this type of counseling, but how could we change that end of the equation?
Jim, I'm personally not aware of other research, and it doesn't mean that it's not out there. I'm not personally aware of it, but I agree with what you're saying is that it's a critically important opportunity to reduce risk that we should take advantage of. And my own view is that if you look at medical journals and whenever the topic of suicide is discussed, it's rare that they talk about access to lethal means. It's all about treatment. It's all about treatment. We need to treat underlying mental illness, of course, and that can reduce suicide risk, but it should be part of the package. And we should rigorously evaluate it.
My understanding from a previous meeting we had was that Florida passed a law that made it illegal for a physician to talk about gun control with any patient at all. And I presume that law is still in act.
Not to talk about gun control, but to ask whether patients, including depressed young men, had firearms at home. Yes,
that was found unconstitutional.
Yeah.
That has been repealed.
So I know of no research. It's extremely difficult to get into medical school curricula, the whole question of talking about suicide, investigating about suicide. I mean, we do things, but it's very, very hard. There are very few residency training programs in something like psychiatry that actually teaches people systematically how to deal with something beyond what someone's immediate mental state might be. So they don't look at all the things that are necessarily going on in people's lives. And I have to critique the DSM movement, and I certainly wrote in an earlier edition of the DSM movement, which has forced people to really look at cross-sectional symptoms and symptomatic factors, less at life history, less at life circumstances. So there really is a belief that the notion is that a psychiatrist treats those symptoms and those disorders as opposed to those lives and those people. And I think that's really been an undercutting, and it's really going to be one of the things we're going to have to work on.
I worked on DSM-5, and I tried to encourage them to include a suicide assessment, not a risk assessment, a suicide assessment every time a diagnosis is made. And we went through it and everybody approved it, but when it got up to the Board of Governors of the APA, said no way we want to do this. So they could have washed it because that would put psychiatrists at risk of medical legal problems. So the idea was that every time a diagnosis is made, some kind of statement about your concern about suicide with this patient will have to be included with the diagnosis to ensure that clinicians keep their eye on the ball, no matter what the diagnosis is. And it was approved at every level until the Board of Governors of the APA looked at it, and they didn't want to complicate problems with the medical legal stuff, and so it was removed from the final edition.
I want to just conclude with one comment that's a tribute to questions that Vicky raised in our working group. And she said something like, we're not only focused on serious mental illnesses like schizophrenia and bipolar disorder and depression, but what about stress and distress that occur? And that may be viewed as impulsive, but if you have a woman who feels that she's in a marriage which is abusive and there's no way out, or if you have a farmer in India who feels that he's at the end of his rope where his farm is mortgaged and he can't provide for the future of his family and there's no way out, are these not types of distress that we should consider as we think about a mental health perspective on some of these issues? But I think there are lots of questions here, and this has been a rich area. If it weren't for the time, we could go on. And I want to thank our panelists, Mike, Michael, and Daniel, and all of you who made very good comments and questions here. It's the end of the day. I'm really sorry to cut this off, but I think it's been enlightening. So again, please join me in thanking our panelists and discussing. And I'll turn it over to Peggy for a summary.
All right. Well, I'm going to delay my summary mostly till tomorrow morning since we're out of time. I had gone through the day and with every speaker listed one nugget from each speaker, but we don't have time to do that. Originally I had 15 minutes, but we don't have time to do that. But I do want to say that we've covered a lot of ground today. And I think the committee, I'll speak for the whole planning committee in that I think it's gone really well. And we've certainly touched on the topics that we thought were important. We've touched on the controversy. Mark said this morning that this is a sticky, wicked problem. I have it written down here. And we've certainly highlighted that. We've certainly reinforced that today. But it's also a global problem. And we've talked about the things that I think most of us on the committee thought were important. I'm looking around the room to see if there are nods from the planning committee. We will continue tomorrow with this section that we're on, which is trying to develop a new model for understanding the intersection between mental health and violence. And so in the morning, we start with a panel on alcohol abuse and alcohol itself. It came up a little bit today in some of the discussion we got from the panelists right after lunch about just focusing on substance use in the mentally ill population. But, alcohol is complicated and other drugs because not only do you have the use of the substance, which can exacerbate issues, as we heard from James Blair, but also we have disorders. We have substance use disorders. So you have both. You don't have to have a substance use disorder for alcohol or drugs to contribute to a violent behavior. But then you also do have the substance use disorders, which when they're comorbid with mental health disorders can cause problems that lead to violence. So it's a complex relationship. So we have a whole panel on that. We're also going to talk more about the criminal justice system and their role, as well as the mental health treatment system. And I think that's pretty much tomorrow, and as well as a summary at the end of the day. I want to just make sure that I've covered everything for tomorrow. The way forward. What can we do about things, which is, of course, the easy one, right? I do want to thank everybody who made it here today, in spite of the weather and everything else this morning. I think tomorrow all we have to deal with is cold, not snow, but cold. I also want to thank the people who've listened in on the webcast. You don't see them in the room, but there is a number of people who are participating today by webcast. And I want to remind everybody that the webcast will start again tomorrow at 8:15. And I think which is right when we start. And we'll start tomorrow. I mean, I am going to do my summary with the nuggets from each presentation, but I figured, that old Far Side cartoon where the student in class is raising his hand saying, "Teacher, my brain is full. My brain is full." So we'll save it for tomorrow when it might be better to do the review. And everybody enjoy the evening and see you tomorrow.